All right, we're going to go in directly into scenario 3 now. All right, so on 3/20, Mr. Sweetheart underwent a cabbage ×3 with saphenous vein harvest. CBGB procedure was performed. His preoperative nares MRSA screening was positive. No documentation of infection was noted within the operative procedure report. On 3/27, Mr. Sweetheart was discharged. On 4/10, Mr. Sweetheart went to the emergency department with complaints of acute incisional pain and opening of his sternal incision. He also complained his leg incision had been becoming hot and swollen over the past week and complained of a small amount of blood-tinged drainage from his incision. The emergency room MD diagnosed and documented a superficial wound infection of the leg incision. Mr. Sweetheart is admitted. On 4/11, Mr. Sweetheart is taken to the OR, and the surgeon documented the sternal incision had dehisced down to just above the sternal bone. Intraoperative deep wound culture was collected and positive for MRSA. The leg incision site was not manipulated or cultured during this OR procedure. What should be reported in this case? Do we have 2 SSI events here, a superficial incisional primary and a deep incisional primary? 2 SSI events, a superficial incisional secondary and a deep incisional primary. 1 SSI event, a deep incisional primary. 1 SSI event, a superficial incisional primary, or is nothing reported? The patient was colonized with MRSA prior to surgery. So remember, you'll want to take a look back at the case scenario to make this determination. Okay, well, let's see what the correct answer is. And the correct answer is B. I hear a lot of... All right, 2 SSI events are to be reported, a superficial incisional secondary and a deep incisional primary. Okay, so we meet superficial incisional secondary SSI criterion D because there was a diagnosis of a superficial incisional SSI of the secondary incision site by the ED physician, remember? That's criterion D for superficial incisional SSI. That's a physician diagnosis. And again, MRSA colonization does not eliminate the patient from SSI surveillance, so most of you knew that. So as you can see here, criterion D is met. But additionally, we have another SSI to report because this is a cabbage procedure, a CBGB. We have 2 incision sites, remember? A primary and a secondary. So we also meet a deep incisional SSI criterion B. The event occurred within 90 days because it's the primary CBGB incision site. It involved the deep soft tissues of the incision. And there was a deep incision that spontaneously dehisced. An organism was identified from the deep soft tissues, and the patient had a localized pain noted. So let's talk about this. Actually, this is a similar scenario would be addressed in denominator reporting instruction number 7. This is one of those procedures, one of the 7 that has a secondary incision site, the CBGB. So we remember that we follow the leg incision for 30 days, we follow the chest incision for 90 days, and you only report the 1 procedure, but you actually have 2 SSI events attributed to the procedure. Does it make sense? Yeah, so 2 SSI events are actually reported here. And I wanted to point out the SSI FAQ. There's an FAQ question that addresses level of infection for the sternal site after cardiac procedures. And this actually, because the dehiscence went down to the level just above the bone, you would apply the deep incisional criteria in this case. And I just wanted to show you this in case you haven't seen this. Sometimes users have difficulty making a determination of tissue level involved in an infection following a cardiac procedure. So now, do you mark PATOS equals yes on the SSI event form? So we've already determined that we have two SSI events here, but would you mark PATOS equals yes? And this is actually going to be more specific to the sternal wound. So would it be yes, the patient was colonized with MRSA at the time of the index operative procedure? So yes, or no, there was no evidence of infection of the surgical site documented in the operative procedure report? Or this is not an SSI, so PATOS does not matter. Is this really 100%? This better be correct. Then we have problems. What? Great job. So the correct answer is, let's see here, B, PATOS equals no. So great job. MRSA colonization is not evidence of actual infection of the surgical site. So it would be PATOS equals no. Also, because there was no infection documented within the operative report of, at the time of surgery, PATOS equals no. So there was no documentation that there was infection seen. All right, let's move into scenario number 7. On 4/15, a 34-year-old female underwent an unscheduled CSEC procedure. On 4/17, the patient's vitals declined, a bleed was suspected, and the patient was taken back to the OR where a HYST had to be performed. On 4/19, the patient spiked a temperature of 38.2. On 4/20, at the bedside, the surgeon noted that the patient's incision dehisced through the fascia. A culture was collected from the deep tissue, and the surgeon did not enter beyond the deep tissue level. On 4/21, a deep wound culture returned positive E. coli. What should be reported in this case? Is this a deep incisional SSI? Criterion B, date of event 4/19, a deep incisional SSI criterion B, date of event 4/20, or is SSI criteria not met in this case? All right, so most people have logged their responses. Let's look at what the correct answer is. And the correct answer, it's kind of covered there. You can see the correct answer is A. The criteria is deep incisional SSI criterion B, and your date of event is 4/19. So let's look at the rationale. Okay. Well, first of all, we know that the deep incision spontaneously dehisced. An organism was identified from the deep soft tissues of the incision by culture, and the patient had a fever. 4/19 is your date of event because this is the date that the first element used to meet the SSI criteria, your fever, occurred on this date. Does that make sense? Okay. Now, this next knowledge check asks, this SSI event is linked to what procedure? So we've established there's an SSI event, but what procedure do you feel the SSI event should be attributed to? Would it be the 4/15 CSEC, the 4/17 HYST, or is SSI criteria not met? Which, if anybody answers that, okay. So the correct answer is B, HYST. Okay. The rationale for this. The SSI event goes to the operative procedure that was performed most closely in time to the SSI event, and that would be your HYST procedure. Remember that the CSEC SSI surveillance period did end at the conclusion of that HYST procedure. And this would be, this is actually SSI event reporting instruction number 5. This addresses this type of situation where you attribute an SSI to an NHSN procedure when several are performed on different dates. So we know that the HYST was performed most closely in time to the date of this SSI event. So great job. It is the HYST procedure that would receive the SSI attribution. Okay, so this poor thing. On 4/23, the fever continues for this patient. A CT of the abdomen pelvis is performed, and findings include suspected abscess in the deep pelvis with inflammatory stranding. A CT-guided abscess drainage is performed, and 150 cc's of purulent fluid from the pelvic space is aspirated. A culture is sent of this fluid. On 4/25, the pelvic fluid culture results return and is positive for E. coli. Now, what should you do next? Do you want to do nothing because the patient already met criteria for a deep incisional SSI event? You're good to go. Or a B, does organ space SSI criteria now need to be reviewed to determine if the deep incisional SSI event should be modified to reflect an organ space SSI event? Or should organ space SSI criteria be reviewed to determine if a second SSI event should be attributed to that 417 HYST procedure? Because we know we've already established that they met deep incisional SSI criteria to the HYST. So what do you think? I'll give it another few seconds here for our web streamers. Okay, well, the correct answer is actually, I don't think it's showing up here, but the correct answer to this question is B. Organ space SSI criteria should now be reviewed to determine if the deep incisional SSI event should be modified to reflect an organ space SSI event. So remember, you report the deepest level of SSI within the surveillance criteria. So now we have something else going on, and we want to just make sure they don't meet organ space SSI criteria. So this is actually SSI event reporting instruction number 1 that addresses multiple tissue levels that are involved in the infection. Now, does the patient meet criteria for an organ space SSI? Yes or no? And the key here is really chapter 17, right? Because your organ space SSI definitions are in chapter 17. It's following a HYST procedure. What kind of organ space SSI events can be assigned to a HYST procedure? Okay, so let's look at what the answer is. My mouse? Oh, there it is. Okay, so the correct answer is A. This is an organ space SSI criteria is indeed met. All right. And the rationale, we'll look at this. The date of event occurred within 30 days of the HYST procedure, because HYST procedures have 30-day SSI surveillance periods, involves the organ space level, and actually, this meets A, B, and C. We have imaging tests that suggest a pelvic abscess. We have purulent fluid from a pelvic abscess that is aspirated, and we have organisms that are identified from this purulent fluid that was aspirated. Okay, so knowledge check number 14, what site-specific criteria is met? Is this an IEB? Is this an OREP? Is this an EMET? Is this a VCUF? Think about where the infection has set up. Okay, I know y'all want to know. I won't hold out on you any longer. Let's look at what the correct answer is. Well, the correct answer is B, OREP. Why would one apply OREP in this situation? Well, infections that are actually localized to the pelvic or the deep pelvic or the organ space, you would actually apply OREP criteria. And in this situation, the pelvic space was clearly infected. Organisms were identified from purulent fluid from this space as well. So actually OREP criterion 1 and 2 are met. So this would be a situation where you would apply OREP and not general IAB. And please note that OREP criteria is actually designated for those infections from the pelvic space and also other infections of the male or female reproductive tract. So it doesn't have to be a reproductive infection to meet OREP, because this is a situation where this, when infections sometimes just set up in the general pelvic space, this is a situation where you would apply OREP. So we know that both deep incisional SSI criteria and organ space OREP SSI criteria are met during this HYST surveillance period. So what do you end up reporting to NHSN? Is this a deep incisional SSI with a date of event of 419 attributed to your 417 HYST? An organ space OREP SSI with a date of event of 423 attributed to your 417 HYST? Or do we report both of these SSI events to NHSN? There. Let's see. Correct answer is B. Organ space OREP SSI date of event 423 attributed to the 417 HYST. Great job. 95% of correct. I'm very proud of you. Very proud. So organ space OREP is reported because remember this reflected the deepest tissue level where SSI criteria was met. Okay, let's move on to scenario 5. On 8/13, Mr. Spine underwent an L4 to L5 posterior lumbar fusion. On 8/17, it was noted that his post-op course was unremarkable and he was actually discharged to rehab. On 8/20, during his rehab assessment, the MD noted clear fluid leaking from his incision line without any evidence of infection. The patient was discharged back to the hospital for a lumbar drain placement. On 8/21, he went to IR for his lumbar drain placement, and the drain was placed just left of the midline incision at L4, L5 for treatment of this leak. Mr. Spine was still without any evidence of infection at the time of this drain placement. On 8/23, Mr. Spine developed a low-grade fevers and intense pain at his L4 to L5 fusion site. So on 8/23, the decision was made to return him to the OR. The fusion site was re-explored, and purulence was seen in and around the L4 to L5 epidural space. Is there an SSI attributable to the 8/13 fusion here? All right, I'm going to see what the responses are. And the correct answer is B, no. Okay, we're going to talk about this. This is why I put it in there. And I don't mean to trick you, but it's a learning opportunity. Okay, because we get questions about this sometimes. Okay, the answer is no. Well, okay, there's definitely an event here. There's an infection. But the rationale is because the fusion organ space operative procedure site was accessed on 8/21 without evidence of infection at that time, right? So they put this lumbar drain into the site, and that manipulates the organ space. So this would be an invasive manipulation that occurred on 8/21, so no longer would you monitor for an organ space SSI event following the lumbar drain placement. Obviously, you can review it. It's obviously meeting criteria for an infection. It just wouldn't be an SSI. So invasive manipulation is a question that we get a lot, and it's really hard, to just address. We can't really address multiple scenarios because scenarios can vary from patient to patient in terms of what invasive manipulation really is. But the general guidance that we can provide and what was met here is that SSIs following invasive manipulation accession of the operative site would not be or infections would not be an SSI if during the post-op period the surgical site was without evidence of infection, and that was the case. An invasive manipulation or accession of the site was performed for diagnostic or therapeutic purposes, and that was the case. They put a lumbar drain in. And then an infection actually subsequently developed at this tissue level that was entered during this manipulation accession. Does that make sense? Okay. Because we do get a lot of invasive manipulation questions, and it's just something that I wanted to address. So here we are again, and this is the same patient, but it's a slightly modified scenario. On 8/13, Mr. Spine underwent an L4 to L5 posterior lumbar fusion. A lumbar drain is placed at the time of surgery. On 8/15, he was doing pretty well, and he was discharged to rehab. Now, while on rehab, he developed some low-grade fevers and sudden intense pain at his fusion site. The lumbar drain was still in place and it hadn't been manipulated. Discharged back to the hospital for an assessment. They did decide to return this patient to the OR, and his fusion site was re-explored, and purulence was seen in and around the L4 to L5 epidural space. Now, is this an SSI attributable to the 8/13 fusion? You haven't fallen asleep on me, have you? You're all a little more coffee. All right, I'm going to close this poll out. Correct answer is A. Yes, 100%. I'm so proud. Great job. So the answer is yes. And the rationale is because, well, first of all, we saw purulence in the organ space. Invasive manipulation did not occur following the 8/13 fusion. That lumbar drain was placed at the time of surgery. It had not been manipulated following surgery. So this actually would meet organ space SSI criteria. C, an abscess or other evidence of infection involving the organ space was detected on a gross anatomic exam. Okay, so remember with organ space, we got to move on now to our site-specific criteria. What site-specific criteria should be applied in this case? 'Cause the patient obviously has an infection, but considering the scenario and where they found the infection, what would make the most sense to apply in this situation? Would it be that you would apply spinal abscess? Would you apply bone osteomyelitis, disc space infection, or meningitis or ventriculitis? Okay, I'm going to close this out. Okay, the correct answer is A, spinal abscess. I didn't mean to be tricky. I honestly didn't. Well, purulence was seen in the epidural space on gross anatomic exam. So spinal abscess is a definition that applies to spinal abscess, subedural, and epidural infection. So we have purulence noted in that epidural space. That's why you'd steer more towards applying spinal abscess in this case. And I also wanted to just make mention, I know Kathy noted earlier in the week, but we actually, Chapter 17 updated this definition a little bit for 2019 just to be able to allow purulent material in addition to the word abscess to actually meet spinal abscess infection. Because what we were getting questions from users that were saying that there wasn't actual per se the word abscess noted, but the patient had clearly purulence at the level, at that level of the spine. So we just wanted to make sure we were capturing these events. So that's why we tweaked this to allow purulence or other evidence of infection as well to meet spinal abscess. So I was trying to tie it all together, and but you did pretty good. Just remember that this is a situation that would be more of the spinal abscess versus disc versus normally like in disc, we would see like the actual disc space or mention of a disc infection or a culture from the disc, a little bit more specific, but it can get tricky. So, all right, let's look at scenario 6. I think we have 2 scenarios left, and hopefully, so hang in there. On 10/3, a 62-year-old female was admitted for an acute abdomen. A CT of the abdomen revealed perforated viscus. An XLAP in a small bowel was performed. The operative report documented gastrointestinal perforation and drainage of intra-abdominal abscesses. The patient had a wound class that was noted as dirty infected. On 10/20, the patient was discharged to a skilled nursing facility. Now, on 10/24, the patient was readmitted back to the hospital with complaints of severe abdominal pain and shortness of breath. The CT revealed free air and fluid in their abdomen. The patient returned to the OR where gross fecal contamination was documented upon entrance into the abdominal cavity and a sigmoid colon perforation was noted. At this time, on 10/24, a partial colectomy and an end colostomy was performed. The procedure ended up being coded as an XLAP and a colo. Is an SSI identified here? Yes, an IAB with date of event of 10/3. Yes, an IAB with date of event 10/24. Yes, a GIT with date of event 10/24, or is an SSI not identified? Okay. Many of you have answered. I'll go ahead and close out the poll or see what the correct answer is here. And the correct answer is D. SSI is not identified. So great job. Let's talk about why an SSI is not identified. Well, there is no evidence of infection noted on that 10/24 operative procedure report. Fecal contamination is not evidence of infection, so SSI criteria is met. There's nothing else that's provided there that would lend you to thinking that an SSI criteria is met. That original procedure, the 10/3 procedure, findings cannot be used to assign an SSI event to that same procedure on 10/3. The SSI surveillance period begins at the conclusion of that 10/3 procedure, and you monitor for an SSI event. So I just wanted to clarify here and also highlight this SSI frequently asked question number 14 that addresses when a patient may have stool or blood in the abdomen, and the fact that this would not be considered abscess, purulence, or other evidence of infection, because we get this question sometimes, and if you ever need to refer to this or provide it as proof, when you're working through your cases, we do highlight this in our FAQ. So we know an SSI is not identified. You can't meet organ space, you can't meet gastrointestinal, and you can't meet IAB. Liquid stool is a contamination, but not evidence of infection. An infection in the abdomen has not developed. So the scenario evolves. On 10/27, the patient's noted to be hypotensive per facility parameters. Patient also has a fever noted of 38.5. Blood cultures are drawn, and a CT is performed. The CT reveals possible developing abscess in the posterior left lower abdomen. Antibiotics are initiated for an intra-abdominal infection. On 10/30, blood cultures resulted 2 out of 2 Candida albicans. Now, is an SSI identified? Yes. Criterion C for general organ space and IAB criterion 2B, date of event 10/24. Yes, criterion C organ space, IAB criterion 3B with date of event 10/27. Yes, organ space C and GIT criterion 2C with date of event 10/27, or is an SSI not identified in this situation? Okay, so let's see what the actual answer is. And the answer is B. So this is we have an SSI organ space criterion C event. IAB criterion 3B is met with a date of event at 10/27. The rationale is that organ space criterion C would be applied because the CT revealed a possible developing abscess in the posterior left lower abdomen. The infection occurred within 30 days. It involved the organ space, and criterion C is met. Now we move on to site-specific criteria to make sure that we can meet a definition there. And we do. We meet IAB criterion 3B with a date of event of 10/27. The patients noted they had fever, hypotension. Additionally, they had Candida albicans isolated in their blood, which is an MBI organism, so it's eligible for use. And we have imaging test evidence that's equivocal for evidence for infection. It wasn't, suspecting abscess, but we have that physician documentation that supports that imaging test finding. So we have physician documentation of antimicrobial treatment for an intra-abdominal infection. So this is actually meeting IAB criterion 3B, and your date of event is 10/27. Now, why wouldn't this be an SSI GIT? Because GIT refers to the gastrointestinal tract, so the lumen of the GI tract, a little bit more localized. And this was an infection that was more so in the intra-abdominal space, so that's why you'd refer to IAB criteria in this case. So what operative procedure gets the SSI attribution? We've established there's an SSI. Would it be the 10-3 XLAP? Would it be the 10-3 small bowel? Would it be the 10-24 colo, the 10-24 XLAP? And then, of course, an SSI is not identified, so attribution doesn't matter. So you'll have to go back in your scenario there and okay, I'm going to just show the correct here, and let's see. The correct answer, 95%, great job. 10-24 colo is the procedure that gets the SSI attribution. So remember, the return to OR on 10-24 for the colo and XLAP began a new SSI surveillance period. So your attribution would go to that 10-24 colo procedure based on Table 4. It's not clear what procedure would get the attribution, and this is why you'd refer to Table 4, where colo is listed higher than XLAP in terms of level of risk. So that's why we would go with the colo procedure. An SSI is identified as PATOS equals yes or no. PATOS equals yes, there's documentation seen during the 10-3 procedure and documented in the op note. PATOS equals yes, there's infection seen during the 10-24 procedure and documented in the op note. PATOS equals no, there is no infection seen during the 10-24 procedure and documented in the op note, or this is not an SSI to PATOS, doesn't matter. Okay, I'm going to go ahead and close, see what the answer is here. And the correct answer is C. PATOS equals no. There's no infection seen during the 10-24 procedure and documented in the op note. Fecal contamination is not evidence of infection. We've established that. You also cannot use the operative findings from the 10-3 procedure to answer the PATOS question for the 10-27 SSI-IAB event. Because remember, you have that new surveillance period that began at the conclusion of the 10-24 procedure, and therefore you would only use those findings that are captured within the 10-24 operative procedure report to answer the PATOS questions to the SSI event that was noted on 10-27. Does that make sense? So you're in that new surveillance period, and so you can only go back to the most recent operative procedure to look for evidence of PATOS. All right, so let's move into our last knowledge check scenario. On 1/15, a 67-year-old man, Mr. Knees, underwent a right capro due to severe osteoarthritis. His post-op course was uneventful. He was discharged to rehab on 1/20. Now, on 1/28, the patient was discharged home from rehab, and his knee was appearing to be doing pretty well. At 2:25, while home, the patient began to notice some mild swelling and tenderness of his knee. He iced his knee and called his surgeon for an appointment. On 2:26, during the exam in the surgeon's office, swelling and tenderness was noted, and 3 cc of serosanguinous fluid was aspirated from the right knee joint space and sent for culture. The patient was sent home or sent to the hospital for admission and IV antibiotics. On 2/27, while in the hospital, the patient's vital signs were stable with a slight fever. The right knee was slightly warm to the touch and swelling was present. The surgeon aspirated 5 cc's of blood-tinged serous fluid from the joint, and the fluid was sent to lab for culture. Blood cultures were also drawn at this time. On 3-1, both joint fluids were reported as rare growth of MSSA. Both the blood cultures were also reported positive 2 out of 2 MSSA. The patient remained hospitalized for an additional 5 days of IV antibiotics and was discharged on home health for 6 weeks of IV antibiotics. Does this patient meet criteria for an organ space SSI? Yes, criterion A, yes, criterion B, yes, criterion C, or no, none of the organ space SSI criterion can be met. So general organ space, does this patient meet criteria? All right. Let's see what the correct answer is here. The correct answer is yes. This does meet general organ space SSI criterion B. Because organisms, MSSA was identified from the patient's joint fluid. So we know that it occurred within the 90-day SSI surveillance period for the CAPRO. It involved the organ space. Additionally, the patient had organisms identified from that joint fluid. Now we go on to determine whether or not we would look at organ space SSI criteria be met. So what site-specific organ space definition would you apply in this case? Would you apply the PJI definition, the periprosthetic joint infection? Would you apply the joint or bursa infection? Or would you apply neither the PJI or the joint should be reviewed? This is a CAPRO procedure. What's available? I'll give you a little hint. What's available for SSI attribution of the organ space following a CAPRO? All right, I'm going to close out the poll. And the correct answer would be PJI. So your answer is A, PJI. So PJI is only applied following an HPRO or KPRO. You wouldn't apply joint in this situation. See? So PJI criterion 1 would be the definition that is met. 2 positive periprosthetic specimens with at least 1 matching organism were identified by culture. The patient was clearly being worked up for an SSI at the time of the visit to the office, so that wouldn't be an invasive manipulation of the organ space. They had to get the patient back to the OR, and then they, got additional cultures. And so this patient definitely meets the definition of a PJI. So what is the date of the event for this PGI? Would it be 225, 226, 227, 31, or there's no DOE because this is not an SSI? Well, we know that. I'll give you a hint. E is not the correct answer. All right, let's see. Still moving a little, but we'll let's see what the correct answer should be for the date of event of this PGI. And the correct answer is B, to the date of 226. On 226, the first element, the first positive periprosthetic culture that's used to meet the SSI infection criterion occurred for the first time during the SSI surveillance period. So remember, for the SSI protocol, the date of event is the date that the first element is used to meet the definition. Now, does the patient have a secondary BSI? Okay. Correct answer is yes. A is the correct answer. Great job. So this is a situation where you'd apply that scenario 1 when we were talking about the secondary BSI two scenarios. This is scenario 1, because positive blood cultures fall within the secondary BSI attribution period for this SSI event. We know that the organism identified from the blood cultures match organisms identified from deep tissues of the surgical site culture. So as you can see here, just kind of using this little picture, our date of event for the organ space PGI is on 2/26. The positive blood culture was on 2/25. So therefore, it fell within the secondary BSI attribution period. Okay, so that completes our cases. Great job. Let me just briefly go over completing the SSI event numerator form. We'll circle back to this picture I showed at the beginning of the presentation. Remember that you have to have all of your denominator for procedure data in the application before you can enter any SSI event data to link it to that procedure data. So the form on the bottom right-hand side is your SSI event data collection form, and this is where you collect your SSI event data. And this is, again, an example of what the form looks like. Obviously, not everybody uses these still, but what's important about this is these are the fields that are still needed to be collected, depending on, no matter how you send your information to NHSN, manual or not manual. The instructions for SSI event numerator data collection are also, we also have a TOI for that. So it'll kind of walk you through how to answer those specific questions on the SSI event form. And remember that you have to complete an SSI event form for each patient found to have an SSI using the SSI criteria. So just kind of briefly looking at this, there's patient demographic information that's at the top of this form. And the fields that I have highlighted here are what's like our required fields to enter into NHSN. And then down below are your actual event detail fields. And as you can see, what's highlighted in yellow is what's required. You just want to remember to select all the criteria used to meet the specific SSI event in order to avoid a validation error alert when entering their SSI event. And so you really want to select those applicable signs and symptoms. Now for organ space SSI criteria, remember you have to meet general organ space, a definition from general organ space, and you have to meet the definition from site specific. So you just want to make sure whatever you're selecting here encompasses both of those definitions. So it's actually the event will save. Oftentimes what it is you just have to select other evidence of infection found on invasive procedure, gross anatomic exam, or histopath exam. And then at the bottom of the form, we ask you the question, how was that SSI event detected? Was it during admission? Was it during post-discharge surveillance? Was it readmission to a facility where the procedure was performed? Was it readmission to a facility other than where the procedure was performed? Whether or not there's a secondary bloodstream infection, if the patient died, and if they did die, did the SSI contribute to death? And if any pathogens were identified, and we'll ask you for information regarding those pathogens. So the denominator for procedure and SSI records must be linked so that the correct risk factor data are matched to the SSI for a given patient. So this is an example of what it looks like in the application. When SSI is selected from the event type field, you want to click on the link to the procedure button. The application then finds the patient data and links the SSI event to the denominator for procedure record. You want to check the box next to the appropriate procedure and click the link button. So sometimes, like this would be an example of a patient that maybe had more than one LAM procedure. So just make sure you collect the appropriate procedure. And after you link the SSI to its corresponding procedure, make sure the remainder of the SSI form is completed and the record saved for linking to occur. And look, you hit save and data are linked together. If you are on the NHSN Patient Safety Component homepage and you see alerts, they are there for a reason. So just as an FYI, pay attention to these alerts and address them. Otherwise, your data could be incomplete and not included in an analysis. So just something to pay attention to. These alerts are there for a reason. And having said that, there's Peppy again. Just had to give you a little more Peppy. And I'm going to open it up now to some questions. I know we have a few minutes before Rebecca comes on at 10:45, so thank you.
Good morning.
Good morning.
So the question I have is relative to items that are incomplete and not included in the SIR relative to the procedure. So sometimes the cases, the queries that we do for the uploads for the denominators don't include the surgery because they haven't been coded yet or a variety of reasons. So we enter those manually. And fill in all the fields on the page, but the complete complement of the optional items in the denominator piece are not included in that manual entry. So my question is, would the SSI that's applied and linked to that procedure be included in the SIR calculation if the complete complement of the denominators are not included in that, the optional items?
I'm going to bring up Rebecca would be better suited at answering that question. She's our SSI analysis SME.
Okay.
So if that procedure is included on your monthly reporting plan and you are able to import or manually enter an incomplete denominator, it should be included in your incomplete procedures alert. So the numerator is not going to be included in the SIR. The event is not going to be included in your SIR numerator if the denominator is incomplete because you haven't been able to complete and link the event yet. So you need to look for your denominator in your incomplete alerts. Complete that, and then be able to link the event to it.
The mandatory fields
Uh-huh.
are entered. The
Okay.
optional fields
Oh,
are
okay.
not entered.
Okay.
So given that scenario, is
Okay.
that considered complete or incomplete?
Now, if it has the required fields entered, it's complete. If it's not, a required field per your monthly reporting plan and the procedure codes, and it's not under your incomplete alerts,
Okay.
then it means you've already entered all the required fields for it, and you've been able to link an event to it, is what you're saying.
Right.
Yes. So once you generate a data set and it's incorporated into your analysis data set when you run the report, if the procedure meets or does not meet the exclusion criteria, then it will be included in your SIR. Because you could have a complete procedure, but you may have an outlier. And we'll talk about this in a second.
Okay,
I'll talk about
I get
all about
it. Thank you.
Thank you.
I had a question with the superficial criteria D with that documentation of a physician diagnosis of superficial SSI. How specific does that verbiage need to be? Does it actually need to say superficial infection like it did in your scenario 3, or could it just say infection of the incision site?
No, you're not going to, physicians don't necessarily know our protocol, so they're not going to necessarily be documented the way we have it written in the protocol. But what we would expect to see is there's some inclination or there's some reference to the incision site. So oftentimes they do say incisional, or there's some words that are put in there that you just have to know that they're referencing the superficial tissue level. It doesn't have to be verbatim exactly what's in our protocol.
Okay, great. Thank you.
You're welcome.
Hi, my question's about the invasive manipulation. So if I'll use a knee as an example, if you have a knee joint that they're suspecting infection, it's swollen, it's red, it's tender, they go to drain it, but it's benign. It doesn't grow anything. It doesn't have any signs or symptoms within that culture. But then later they progress to a joint infection. Do you work up because it was done thinking that it was going to be effective?
It really depends on the details of the case, and I don't know, how what later means, how far down the road. But
Well, say it's within
oftentimes,
the-
if they're working it up and they're really suspecting an infection, then probably more than likely they're going to continue to work it up, and it may
Right.
not necessarily be an invasive manipulation.
Okay.
But it just really depends on the situation and why they're going in and what they're doing. So. but I mean, obviously, if you have if you have a specific case, I'd be happy to look at that and we could go through it. But it just really depends on the details. But it sounds to me like if they're really suspecting it, then it may not be in a form of invasive manipulation.
Okay, so if they're suspecting it and then it does meet the criteria, that doesn't necessarily exclude it because they drain the joint.
Correct.
Okay, thank you.
You're welcome.
Hi. I have a question. How does the guidelines with NHSN compare to NSQIP? Because with the American College of Surgeons, when I identify maybe an SSI and I sit down with the head of surgery, they follow those guidelines. And we have a differences of opinion. Right. So how does it compare?
They're actually pretty closely aligned. Our SSI criteria and the NSQIP definitions, there's some differences, but for example, they also have PATOS, and their PATOS definitions are very similar to ours in that they don't allow culture results and path reports. So they're not exactly the same, but they're very much so closely aligned, our definitions to NSQIP.
So do you reference their guidelines?
We have our own specific guidelines, so no, we don't reference their guidelines.
Okay. Thank you.
Oh, I guess I'm out of time. If there's any additional questions, you can go ahead and grab me. So I appreciate it. Thank you so much.